I'm very, very happy to get to meet this group. I think that there's a lot of overlaps with my interest areas and the opportunities that you have in your area of work. So I hope this is the beginning of a long relationship. And you'll see that relationships are part of the content of coordination. I'll just give you that preview so you can be thinking about that as I share some of my thoughts about this area of how to coordinate care across the continuum of care and using research in practice. So I don't have any conflicts of interest. And what I'm hoping today is that all of us together will learn about more deeply what is coordination, what is care coordination, what is the care continuum, and how does care coordination bridge that care continuum, and then what kinds of practical tips might be take-homes from relevant research in this domain, really the intersection of these domains. So I wanted to start with just giving kind of an easy picture of what care coordination is. When I first started working on care coordination, it was about 2005, so quite a while ago, and it was becoming an area that as a nation, we had prioritized as cross-cutting and important because early evidence was showing that gaps in coordination of care had real consequences for patients and for the value of care delivered. So the first question is, what does anyone think about when they think about what is care coordination? What would be the active ingredients of coordinating care? So here's a lot of words that have come up through the time that I've worked on care coordination in terms of what people think of care coordination. This is not research. This is just the download. You could add words if you wanted. I've made some words a little bigger because I know they come up more frequently. So communicating, organizing, meeting patient family needs, synchronizing. But really at the base of care coordination is care. So we can't forget that. And in that early work, that was a constant challenge, is how do we scope what care coordination is when it really is everything? But if you're going to work in an area and you're going to do research in an area and you're going to try to make improvement in an area, it's helpful to try to define it with like fewer words and with something that's more a sentence. So we worked on that in the early work as part of an evidence-based practice center project on closing quality gaps, and worked on trying to define care coordination. And being evidence-focused researchers, we decided to look and see how others had defined care coordination and found over 50 unique definitions. Those definitions were brought together to give us a single definition that's actually cited quite widely. And it's often referred to as HRQ definition, which it is. They commissioned the work, and we just did the activity and needed a definition for the rest of our work, which was to look at what the research was on how coordination was actually affecting care. So for us, this was a working definition used to be able to find the right literature to understand how care is coordinated and well from interventions. But I want you to pay attention to certain parts of this definition, and we'll break it down a little bit further, because before writing this definition and going through a whole feedback process with a technical expert panel, we looked at what was in common across those 50 definitions and found 5 main things that were in common. Here I've bolded more than 5 areas. So I would focus on coordination as deliberate organization. It's not just the free-for-all that happens to coordinate care. It involves all of the patient care activities that occur between people, participants in the care. That care includes the patient. So you can see that there's hardly any activity that wouldn't require some coordination between at least the patient and a care provider. Involved in a patient's care to facilitate the appropriate delivery of healthcare services. So there's a goal. There's the desire to make sure that appropriate delivery of services occurs. Further, organizing care involves marshaling of personnel and other resources. So the resource effort needed to carry out all required patient care activities. It's often managed by, importantly, the exchange of information among participants responsible for different aspects of care. I probably should have bolded responsible too, because how responsibilities are apportioned in care coordination is often quite invisible and where a lot of the difficulty lays. That's another foreshadowing. So as I mentioned, we looked at all the definitions and were able to tease out 5 common elements, or at least 5 elements that some of the elements were in some of the definitions, not necessarily all 5 elements in all definitions. But once we had these 5 elements, we had a pretty exhaustive list of what was needed to be considered in a definition for care coordination. So this idea of the numerous participants, the idea of the fact that the participants are dependent upon each other to do disparate activities, the idea that to carry out activities in a coordinated way, participants need knowledge about their own and others' roles and available resources. So the synchronization of resources, the marshaling of resources. And the 4th, in order to manage all required patient care activities, participants rely on exchange of information. And 5, integration of care activities has the goal of facilitating appropriate delivery of healthcare services. And that may seem just so obvious that there has to be a goal. But surprisingly, many of the definitions did not get at the goal. Now I want to turn to this other concept that's related and ultimately bring them together, because in the area of clinical care that everybody in this department does, the continuum weighs heavily. The continuum from Webster's dictionary is a continuous whole, quantity or series, a thing whose parts cannot be separated or separately discerned, which is very interesting, because when we think about the care continuum in healthcare, we often think more about the separate pieces that might be drawn together, but not necessarily that they are integrated and working together, because they so often do not actually integrate well. We have such a fragmented healthcare system for more reasons than anyone could cover in even the beginning of an hour. So I know we all know about that. Still, in terms of thinking about the continuum of care from a healthcare perspective, I like this definition that came about in 1997 from a really fabulous nurse researcher, Jerry Lamb. And this is kind of on the cusp of managed care. So it was the idea of how we're going to manage care, which was more of course, a payment model as well as a delivery model. But here, what she has defined continuum of care, an interrelated array of services from primary to tertiary care, from community and ambulatory services to institutional services and back again. This continuum has been pictured in linear and circular forms, usually with extensive feedback loops. And I didn't put bolds in here, but the extensive feedback loops, clearly part of the challenge in a continuum of care. Another aspect of the continuum of care that the same article covered, and I believe is really important to appreciate as we move in more and more towards ideas of population health and value-based care, is the notion that if you're going to try to visualize this continuum of care and then perhaps figure out how well a healthcare team or system or any effort is doing in terms of delivering good outcomes across that continuum, think about the areas of effort and work to care, and then the possibility of looking at the outcomes. You can look at the levels, at the program level, that could be a unit, the ICU as the patient comes in, home health. You could look at a particular program and approach that's being used for a particular patient population. We're going to try to get patients seen more quickly and put effort there, put process improvement there, and that's our program level effort. So it can either be institutional boundaried or it can be boundaried by a scope of work. That's one level where outcomes could be measured. The next level where outcomes could be measured would be around transitions of care. That's clearly part of any continuum of care. And I'll get into that more soon. You can think about a more global level, like when you integrate across entities, what are the outcomes across entities for a given patient? Or you can look at population-based indicators. So for populations of patients across everywhere that the patients in that population get their care. So the idea of the continuum isn't some static concept. It's something that you have to put the boundaries around in order to think about how to research it and how to practice in that continuum. But from a patient-centered perspective, the bottom line is, does all the care occur in a way that is holistic, where all those parts are actually drawn together and integrated? So I've been trying to learn a little bit more about the work that I believe all of you are participating in and doing. And so I spent some time on one of the, looks like one of the professional organization sites, and listened to some talks and found this really gorgeous diagram that was done during, it was a mural created during a series of talks that I listened to about, and I would love to be able to, if people use the hand thing, if you've seen this, if you could throw the hand up there just so I have a sense of whether this is new to anybody or if this is something that's commonly understood, how to think about, okay, we're seeing one hand there, a couple hands, okay, great, thank you for being a little interactive with me. But what I found very appealing about this particular way of capturing how the field of physical medicine and rehabilitation thinks about its place in patient care is that I could look at this diagram and I could listen to the talks and I could hear where the incredible challenges and opportunities related to coordinating across the continuum sit. So they're right in the middle of this was explore new models in the acute and post-acute continuum. Like, what are the models of care? How do we make sure to give care across the continuum? And what a key role physiatrists and the team that they are leading and facilitating and catalyzing play, and how the future needs more of you. I bought that. I definitely bought that. And then I got very intrigued by what have I learned in my research career that would be applicable and useful in your world. So this is where my motivation came through more deeply. I was already very intrigued and very thankful to be invited to talk to you. But looking at this, I could see the challenges that are faced and the ways that that physiatrists and the community around you are thinking is very appealing and interesting. So on this diagram, I'm leaving this diagram up for a few minutes since there weren't like a zillion hands. You'll see down in the bottom right quadrant, there's things like communicate, there's things like putting the pieces together. And then over on the left side, there's a bit about address gaps. And then there's some bit about targets and meeting goals, which of course relates to what I was saying about care coordination. How can you meet any goals without addressing those gaps and coordinating, communicating? So, good team was down there in that bottom right side too. Every part of this could relate to how to deal with the continuum, through the lens of coordinating care. Which gets me to the next section of what I want to convey, which is thinking about how care coordination, the work that's been done on care coordination, is critical for bridging that care continuum, how working within that care continuum and making sure that for patients, it's as smooth and seamless as possible and is felt as a whole, because that's the idea of that Webster's definition. What I've integrated here in terms of what I've worked on over the years is a pretty short list of what I think is worth paying the most attention to. If you have an interest in bridging between what we know about care coordination and what you experience in terms of playing some role across the care continuum. So attention to gaps is really big. In the early days of getting involved in care coordination, I was working with various clinicians, people in organizational science, the area that I draw a lot of my expertise from, management, and again, the issue of where are the gaps, that we're trying to bring those separate pieces together. And it just may seem obvious, but sometimes you have to state the obvious and put it at the top of a list. And then, what health entities are involved. So, we could put our blinders on and just look, narrowly at one entity or a work group within an entity, or we could look across many entities. But it depends on what it's trying to be accomplished in terms of, so it's a question, what entities are involved in what we're trying to accomplish. Another area of focus that I believe is pretty important, and was part of some of the early measures of coordination, had to do with transitions, managing transitions, and noticing, again, back to the gaps, whether the transitions basically reduced the width of the gap, maybe even shrunk it to nothing if it was an amazing transition management approach, and being able to see where there were lesions in the transitions. Measurement's another area that I've done a lot of work on, so I'm very biased. I believe measurement can be useful at the patient level in terms of the feedback loop that's needed to see how the patient is progressing, but measurement of the various systems is also powerful as long as it's done well. It can be done very poorly and cause more harm than good, just like medicine. You have to be careful. But including granular care coordination measures to assess success within domains of coordination. And I'll get into this idea of domains of coordination also. The central role of teamwork and communication also can't be understated. It's the bread and butter of coordinating care across the continuum. I wanted to show this visual also, another pretty visual, which is what I refer to as a visual definition. As my team, which had originally thought about what's the definition for care coordination, and then worked on understanding what interventions have been done in care coordination and how some certainly contributed to better care and higher efficiencies. We worked on looking at the entire landscape of measurement and care coordination. Who had measures, what the measures were, how well they were working, and created a care coordination measures atlas. And in that atlas, which was updated also, we developed this visual and then some cases to describe what's going on in this visual. And the key part of this visual, even though I would usually say the key part is right in the middle, meeting the patient's needs and preferences and the delivery of high quality, high value care. I would usually say that's the key piece of this diagram. But for our purposes today and for our talk today, we're not going to get there unless we appreciate the white spaces between the various activities and care touch points. So whether it's specific clinical areas like primary care, or one type of specialty care versus another type of specialty care, whether it's an activity like understanding a medical history or getting to the point of having test results, or a domain like home care. And what's added here and is not in the care coordination atlas is insurance, because certainly the management of how care gets paid for becomes something that can be a barrier to being able to coordinate care well, or being incentivized to coordinate care well in terms of the payment models that come through that mechanism. So the key here from the perspective of bridging between the continuum and what we know about care coordination is the white spaces. I just want you to appreciate that there are a lot of white spaces, and you could add a lot more circles and you'd see more white spaces. I've mentioned a few times the idea of healthcare entities that play distinct roles, and perspectives matter in health entities. And in this slide, I switched my slides up. It says again, perspectives matter again. And I'm going to get into perspectives separately because I decided that it would actually be helpful to think about the entities first. And because to get to the point of being able to coordinate care better, just like body systems, you need to have an appreciation for the numerous entities that exist. If you take a patient-centered perspective, or if you take a healthcare professional perspective, or you take more of a systems administration perspective, it's easier to see some entities rather than others, but the whole picture emerges when the list of entities is developed by those three perspectives. Let's play this out a little bit. The patient and family perspective, entities would be something like my individual healthcare provider that I'm interacting with, a nurse, a physician, support staff. If you're a healthcare professional and you think about that perspective, entities might be, my work group, my nursing work group, my physician work group, my support staff work group, my clinic. And there could be like provider groups, my primary care practice, my specialty practice, urgent care clinic. So there's some overlap there, but you can get the idea of depending on which person you put yourself in the head of, and then try to describe what the entities are. It could shift a bit. And then from a system perspective, those who are trying to put it all together in some way, or at least support what's going on, entities would maybe be like the groups of providers that act together in a unit. So a medical unit in a hospital, the hospital as a whole, a specialty clinic within an integrated system, different clinical settings within the healthcare system overall. So like all of the ambulatory care, all of the inpatient care, all of the emergency care. And then if you want to scale it up even farther, outside of a unified system, the picture gets even more complicated. And that's where thinking through the lens of transitions and how transitions are managed is another analytic approach to laying out what the challenges are in some sort of boxes that can allow action and feedback loops in terms of being able to measure what's going on and observe what's going on and try to intervene and change as necessary to make the work in a more coordinated fashion across the continuum. So I highlight, remember in that list, I had gaps and then I had transitions management. So transitions relate to entities and they relate to time. So think of transitions as these points and they're points where information and or accountability and responsibility for an aspect of the patient's care is transferred between two or more entities or is maintained over time by one entity. So there's the play of time and there's the issue of entities in terms of what triggers a transition. And there's some details here. I won't go into them. You live this, you know this, but from a analytic perspective and a trying to make improvements perspective, I just emphasize the idea of transitions are related. They can be related to entities and they can be related to the passage of time or some combination thereof. As I mentioned, I changed up my slide order a little bit and left this idea of the different perspectives and the details of that for now instead of originally. Because it's easy to say there's these different perspectives, but it's better to be able to stop and think about when they matter and why they matter than just to tell you, oh, they matter. You can't think of care coordination. You can't think about integrating across the continuum without sitting in different perspectives. The whole picture isn't there. And so by giving you the examples of the entities and the transitions, I think it's easier to appreciate how critical it is to have a multi area perspective lens. And this came up in working on measures of care coordination, that we needed these different perspectives because the measures that exist often focus on just one perspective. There's data, the data source is one perspective. So if you ask patients or their family members, and I say family, it can be any informal caregiver who's, you know, friends, family. You can survey patients or caregivers about their experience of coordination of care. You can also survey healthcare professionals. You can survey one type of healthcare professional or another, or teams of healthcare professionals. You can ask healthcare professionals to reflect on their own actions and caregiving practices, and have that be kind of an audit-oriented sense of how coordination is working as a line of visibility, or a not quite a quantitative measure unless you bin it, which you can. That's another way that some measurement work works. And then this idea of the systems, the person or the folks who are representing the system, you know, administrators, leaders, who have some responsibility for a whole unit or a whole group, or a whole target of activity, like a particular patient population. And again, a data source for measures, because I've said it's helpful to have measures at a granular level of care coordination. There are measures that are surveys of these kinds of folks. Same clinician leaders can respond on behalf of their organization, not their own specific actions. The medical record has information that can be used. And administrative claims data has been used also in terms of thinking about handoffs and other metrics. Harder to get at the details of coordination and administrative data, but there's some measures that come from that data source. And there I would mean you know, being able to look across different groups, because you have more common information across groups, so higher level analysis. And keeping the focus on measures for just a little while longer, because I said that's something to pay attention to. That I know in your area, you pay a lot of attention to the idea of the patient's trajectory over time, and being able to monitor how well the patient's functional status is improving over time. But the same can be said for looking at how well the coordination that allows the care to happen in a synchronized way, that allows the patient to get what they need to end up getting the outcomes that you want for them. We have to be able to parse this idea of coordinating care in order to measure it. Not just one big concept, just like you parse the idea of functional status and other ways that you get a line of sight on how well the patient's doing. You know, there can be biologic, there can be observational, there can be a lot of ways of looking at the patient, there can be a lot of ways of looking at the system. So, you know, in this work, this is again related to this atlas of care coordination measures, where we were looking for who's tried to measure care coordination and how have they measured care coordination, and how can we assemble all of the evidence on these measures of care coordination in a way that is accessible and also advances our understanding of care coordination. So we developed a framework for measurement and created these categories of subcategories of care coordination based on, again, integrating a lot of other research at the time. And this also has had some staying power. So I hope this is helpful to you, but the idea that coordination activities are one area where you could think about the domains, the subcategories of coordination. So things like establishing accountability or negotiating responsibility for a particular activity set that would be coordinated together, communicate, and there's actually subcategories of communication, facilitating transitions. One that is prominent in a lot of work where complex care is being coordinated is the idea of the proactive plan of care. What is the plan of care, and has that been has it been used? What is it? There's various ways to ask questions about the plan of care, and so forth. This last one on this list of coordinating activities, aligning resources with patient and population needs, and actually the one before too, linked to community resources, came more out of the pediatrics world, working with kids with special healthcare needs, so pretty complex patients over a long period of time, and the idea that not everything is limited to the healthcare domain. I think the learnings there in terms of coordinating care can be useful as we think of aging populations and other high complexity environments. We also developed some domains related to an idea around like broad approaches, efforts that were being made to coordinate care, targeted at coordinating care, and so there were measures that were developed around that. Things like teamwork, there was a healthcare home in the primary care setting, care management at the time was big, medication management has persisted, and health IT enabled coordination. So the broad approaches were a bit more linked in time to when we were evaluating what measures existed and wanting to map those measures to areas that people were working on. And this is just to give you a slight sense of what's out there in terms of care coordination measures. From the update, which was done in 2014, ARC funded that, and they haven't funded an update since. We found 101 measure instruments that assess multiple domains, most measures that relate to care coordination, some either care coordination as a whole or parts of care coordination that I've shown you are pretty agnostic to the clinical domain. I mean, some are targeted right there, you know, melanoma care, but many of them are cross-cutting and would be useful in any environment. And what this shows is it just shows for those 101 measures, how many measures have within their measure, many measures are survey measures, something that relates to the subdomain. So, you know, 50 or so out of the 101 measures, about half have at least, you know, one question, possibly more questions on something related to this idea of accountability and responsibility. Many have, you know, 90% have something related to communication. It's actually surprising that there's any that have, like, don't have any information about communication, but you can see that that's, this is kind of what lays out in terms of measurement. And the Care Coordination Atlas has these measures and has them mapped to the domain. So you can have a quick look at whether a measure covers domains you might be interested in. There used to be a searchable database, but unfortunately it's not available anymore. And now I want to turn, you know, I've been talking about some of the research I've been involved in and how that's been boiled down in my mind and what I've been trying to do in terms of giving the mental picture of breaking down both the context of across the care continuum and the effort to coordinate care. I now want to pivot a little bit, or extend, I should say, extend what I've been talking about to highlight some of the work that's been done in an area of care coordination that I have found from the beginning of my work in this area. So for the past, you know, 15 plus years, to be very powerful. And it has continued to become, I believe, you know, more and more understood as important. And then the willingness of any group to start to draw from this area that I'm going to talk about is something that I don't think I've seen a group yet, and I've been involved for a long time in kind of the collaborative world that cares about this area of work. I don't think I've seen any group that hasn't found something from this very useful. So I'm going to go deeper into one part of the research space related to an approach to coordinating care, which has been called relational coordination. And that sounds kind of, I don't know, touchy-feely, but actually it's not the soft stuff. It's pretty critical. And it relates to teamwork and communication, measuring and intervening. And as I said, there's a growing application of this. So the community that's involved in drawing from relational coordination concepts has tried to share what they've learned, you know, like a professional group. It really is. But it's a group that's comprised of people who are practitioners and people who are researchers and people who blend between the two areas. So it's both very practical and very much about advancing theory and measurement. And I'm very hopeful that I've I moved from Stanford fairly recently, and it took my community there many years to start to notice that it was useful and could be helpful. And I've been gone for about a year and a half, and I hear they're now going gangbusters with this. And I can only hope that I was planting some seeds, and now I'm hoping that the seeds here at Hopkins sprout a little faster, because there's a lot to be learned from this kind of vantage point. So let me dive into this area as a way to translate research into practice. And just to give you a little bit more background on myself, since I'm partly being introduced to the Hopkins community by having a chance to talk to different groups. The areas that I've spent real time in this area of research have been, first and foremost, having discovered this set of ideas in that early work on defining care coordination and understanding what the theory was and how to relate that to interventions and measures. I found this work when it was pretty new and early from a researcher at Brandeis who had studied the airline industry and come up with this concept of relational coordination. And it hadn't been applied to healthcare too much at that point, a little bit. So it was promising, but it was relatively new at that point. And as I started finding out more about it and working with other people in it, I was part of the group that started to create more of a collaborative around the concept to generate shared learning over time in this area. And so it was called the Relational Coordination Research Collaboration, and to have like conferences and have resources together. So kind of a membership organization, but also very open and trying to be public facing and have the knowledge that was accruing be available in this community as well as outside. It's recently changed its name to the Relational Coordination Collaborative, RCC, to try to make sure there's not this big distinction between research and practice. And it moved from being kind of shepherded and stewarded at Brandeis University, where Jody Hoffer-Gattel is a professor, to the University of New Hampshire, where another of one of the early leaders in this area, Margie Godfrey, has recently moved and has set up a way to be able to help continue to provide the glue for this collaborative. And I've been the advisory board chair for quite a few years now, and was, as I said, part of it as it was a developing community of researchers and practitioners. Recently, we've put together a memorandum of understanding to make sure to be concentrating on the research aspects of this across the two institutions that have hosted this collaborative and Johns Hopkins. That's a little background just to tell you this is an area of serious interest of mine, and so what I share with you, if any of it seems applicable and useful, feel free to come back to me for more. I'd be glad to work on problems in this area from a strong marriage between practice and research. I've also just got up here a few things about working within the VA system on care coordination and trying to translate between what we know in research and what we know in practice. And there's a couple of papers on that, and some areas, other areas of work, thinking about time pressure and how that works within team dynamics and patient experience. And finally, since I've gotten here, I've had the pleasure of working with a group that isn't too far afield from your group, and that's the Brain Rescue Unit. And so there's a project underway, and there's a few slides where I pop in from work with them. They're working on bedside rounds intervention and measuring care coordination through this lens of relational coordination, as well as other teamwork approaches. Let me just give you a short but high-level view of this set of ideas around relational coordination as a good translation from research and practice. So first of all, I mentioned that this came from the airline industry first. And so when this was done in the airline industry, the idea was, getting people from point A to point B on a plane. And so in the middle of the vast network of various roles that would have to be coordinated to get each of us from one point to another on a plane, so things like baggage handlers and pilots and so forth, was the customer, the person flying. Here in our healthcare application, patients and families are at the center of all of the work, all of the activity that's being coordinated. And these bubbles around this basically social network are the roles that can be active for care. And you could fill these circles in with any definition you want of any role. It's flexible in terms of thinking. The key here is that different roles are involved in coordinating care where work is interdependent across the continuum. Another way to view the challenge, besides just that, what looks like practically a spider web, is to break it down into more of, if you're familiar with the Donabedian quality of structure, process, outcome, you can break this idea of the challenge of coordination down into, there's structures, there's within unit structures, there's outside of the unit, how you might coordinate across units. Then there's the processes that relate to coordinating care and the people in their roles. Instead of looking at it just at the individual person level, but look at it at the role level, is a way to activate interventions and change and processes that are more sustainable. You're not all dependent on one person doing things in one way. And so thinking about sort of the standard approaches at the workflow level and other aspects of the process of coordinating care. And what I've got here down at the bottom is the work situation or the task. It's something that's sometimes underappreciated also, is that the structures that are needed and the processes that are needed to get the performance outcomes related to what is better for patients and what's higher value, sustainable for a system, sustainable for those working in the system. The way to get to those performance outcomes, what needs to be set up, is going to vary depending on the specifics of the work situation, of what is being accomplished through the task. So one way to think about this is, when you diagnose a patient, how complex the patient is, if there's multiple conditions underway, multimorbidity, and versus a singular challenge, one injury, one set of treatments that are going to happen and make the patient well. The idea of looking at a work system and thinking about coordination, there's been a lot of work that shows that these three elements of the work situation or set of tasks that are most predictive of how much coordination is needed, like the dosage of coordination that's needed, and the fit of one form of structure or one form of processes with what's needed to get the outcomes, is how interdependent is the work that's done among different roles, and keep remembering that the patient is part of the team. Uncertainty, how much uncertainty is there? If there's more uncertainty, then the level of effort around how to coordinate and the ways to coordinate are going to become more nuanced. And time constraints. So the more there's time constraints, the more severe the time constraints, again, the set of coordination processes and the structures that need to be in place become a different set. And I sometimes just like to use the word a more powerful set, a more intense set, like a dose response. And there's research that shows that. Relational coordination is, as a concept at the core, very helpful for moving from like being useful less interdependence, less uncertainty, less time constraints to higher levels of all three of those. So it becomes more and more important as you get higher levels of those three, because there's more roles who are combining their work, their interdependent work, and there are more time constraints and there are more uncertainties. So it's a concept and it's a way of approaching the problem of trying to make coordination better across a continuum that can work from that lower level of task challenge for coordination up to higher levels, but it's particularly useful for as it gets more complicated. So I've been talking about relational coordination. You've had a mental map of what you think it is, perhaps, and now I'm gonna let you know how it's defined in terms of when it was first observed in the airline industry, comparing different airlines. Dr. Gattel created this definition: a mutually reinforcing process of communicating and relating for the purpose of task integration. And what's been seen through the research is that improved team and system performance when relational coordination is stronger, and relational coordination has to do with the relationships and communication. You'll be seeing these a few times over. The relationships break down into, are there shared goals? Is there shared knowledge? And is there mutual respect? And the communication elements break down to, is the communication frequent enough? Is it timely enough? Is it accurate enough? And is it problem solving enough for the task, for the work situation? And then worse team and system performance is seen when you have less of each of those. And so relationships maybe just have functional goals, they don't integrate, knowledge gets pretty exclusive, and there's a lack of respect. These are all hallmarks of poor relational coordination and are associated with poor levels of performance. And similarly, on the communication side of the relational coordination concept, too infrequent, too delayed, too inaccurate, and blame shifting communication instead of problem solving communication are markers of what you're going to see as poor performance. And here I bring in a slide. I'll bring in a few slides from the Work with the Brain Rescue Unit work where they're using relational coordination, and they've pulled together this idea of the for better and for worse approach of what you know from relational coordination, and this idea that we're communicating and relating for the purpose of task integration, and that relationships are shaping the communication through which coordination occurs. And as I said before, we can focus not just on the personal individual level, but we can focus on the role level too. This construct of relational coordination is that it's a measure at a network level, the network of ties among stakeholder groups. And anytime it's used, the group figures out who the stakeholders are and decides what boxes to put them in and develops the survey based on that. The survey is a 7-item validated tool to get at those 3 relationship concepts and the 4 communication concepts. And as I said, work group role is part of the measure and part of the concept. Interdependent task is part of the measure, and it can work across clinical domains. It's been applied outside of healthcare a lot, and there's really significant research on the construct and its utility. So there's a very recent systematic review of 233 studies, and there's a new RC interventions database too of many interventions that have been done in this area. So again, another slide from our counterparts within the Johns Hopkins system that just shows this idea of the sort of feedback loop between the relationship aspects of the construct and the communication aspects of the construct. Measuring RC, these 7 constructs down the left-hand side are asked, questions are formed to represent each of those constructs, and they're tailored to the particular work situation. So here's an example for post-operative care procedures for our surgical patients. And so you'll see that coming through each of those 7 concepts. And I pulled in the one that's just been done for the brain rescue unit. And so here, the work situation relates to the patient's care plan for the day. So how frequently do people in these roles, so I'm in one role and it was asked for do I get what I need from somebody in another role? I'm the physician, do I get what I need from the nurse? I'm the nurse, do I get what I need from the physician? You know, how frequently do people in that other role communicate with me about the patient's care plan for the day? I'm also asked about it from the perspective of others from within my work role. And that creates the data set of how the varying work roles are in dyadic form, what levels of communication they have on these 4 dimensions, and what levels of relationship factors that matter for getting the work done that exist. In the brain rescue unit, here were the roles that were surveyed. So again, there's a lot of tailoring. The group had to spend time figuring out how they wanted to consider who the stakeholders were that might be affected by bedside rounds and who might be affecting the ability to coordinate through that mechanism and the care, you know, having the care plan for the day. So this was the set of groups, but it's up to any group that's trying to focus on a particular area of coordination to decide what the roles are. And it can be done within a unit like this, or it can be done across units or across even entities if entities get together to think this way. And this is, you know, without data, but the idea of, you know, each group is saying on a 5-point Likert scale for each of those questions, whether they're, you know, constantly, never versus constantly, and everything in between, having that element, the frequent communication, the problem-solving communication, et cetera. And then from that data, and I'd like everyone to think also about, you can do this in a numerical way or banding it as sort of weaker relational coordination up to stronger coordination from these concepts of relational coordination. You can also, I've seen this used pretty effectively in early stage work without actually doing the measure, just having groups, and I've done this in my research teams too, ask themselves questions about, you know, okay, here's the roles. How do we think the roles are communicating with each other? What do we think the shared knowledge is, et cetera. So you can use these concepts qualitatively or quantitatively. And, but if you do it quantitatively, then from the survey, these types of pictures come out. And they can be very helpful to being able to sit down with a group and have a status, sort of the current state of one work group to another. So what this means here is like the red work group is within themselves weaker, and the green work group within themselves is very strong, and the colors that connect are related to how the dyad works. And you can get the network findings in this, and you can get a matrix of findings in this to see every pair, how they work in dyadic form. And then I'm going to end on this because I know we're at that point of having to end. But and this is the sort of pièce de résistance from my perspective in terms of applying relational coordination to a work area. And so this is the idea of the general approach for bridging the continuum through RC and the roles lens, is that there's structural interventions, things that often middle and top leadership would be considering and can intentionally focus on in terms of how it supports higher levels of relational coordination. There's this concept of relational coordination in the middle, and there's the performance outcomes that we care about on the right-hand side. And then undergirding all of this are actual relational interventions, things like humble inquiry, coaching, creating safe spaces, the idea of you know, the culture of safety or the cultures that lead to higher quality. And then the work process interventions. I mean, it could be things like lean and regular quality improvement, but through the lens of understanding the current state of this interdependent work done through roles and identifying the desired state and looking at the gap. And that's a very frontline activity. So it's the frontline workers, it's the frontline leaders, it's the patient's families, whoever the quote client is that's co-producing their own care. Looking at what's happening relationally, what's happening in terms of work process, but it has to be supported by structural interventions. And then when work is done in each of these areas, you get higher performance. And the systematic review that I mentioned has a lot of detail about this. So I'd recommend it if you're interested. And I'll conclude there. And thank you for your attention. And I hope I get to meet you all in person at some point. I speak Preeti, and I've gotten to meet her in person. So well, sort of, I guess it actually hasn't been in person. It's been all this way. It feels in person over time.
Thank you so much, Kathy. This is awesome. Just to let everyone know, I came across Kathy's work and I felt that it was so integral to what we do in PM&R, because we are constantly looking to sort of bridge the continuum and make sure we shepherd our patients through all of the transitions. And there are just so many opportunities where things don't go well, right? And especially as we move towards, implementation science and implementing best practices that are now out there in the research and have to be incorporated into clinical practice. I think what you are, what you've presented becomes so very relevant. So I guess I know we are running out of time, so I just want to ask one quick question. If somebody wants to get in touch with you what would be the mechanism to sort of say, okay, we have a project and we would like to sort of avail of relational coordination?
Yeah, I was thinking about that because I just think this area, we could learn so much together. So, I just say, reach out to me and we'll figure it out. I've been interested, the Brain Rescue Unit has been actually working for a couple of years. They brought together, varied folks and are meeting regularly and have, gained a lot from these concepts. And, I've also worked with, others at other universities who are trying to draw from this. So I can be a bridger, I can be an active, participant in projects. There's so many ways to be involved. So I'm actually very eager now that I've learned more about, thank you, Preeti, for the noticing the connection, because I'm sure that we could do a lot together and learn a lot together and make a real difference for the patients and the field. So get in touch. Email me and we can meet. I can meet in group. I can meet individually. Whatever works. But I'd be very oriented towards making a difference.
Thank you, Kathy. Any other questions from the group?
I hope it's relatable in some way. That's my main hope.
I think people have a clinic starting
sure.
at 1 o'clock. So thank you again, Kathy. I'm sure you will hear from a few folks, and we look forward to working with you.
Yeah, and I'd be happy to come back anytime too, do sort of a part two. I think that there's a whole range of work of thinking about the co-production, with the patients and families, and this idea of the relational coordination in the middle among all the workers, and the relational leadership that's needed in terms of at the higher levels of an organization. So really powerful concepts, and be glad to spend time in this format. If there's an interactive way to do it in this format, happy to do that next time too. So thank you so much.
Great. Thank you.